Yeah, so today my topic is I'm going to talk about toxicities associated with intracranial SRS and hypofractionated stereotactic radiotherapy. This term basically is the standard term. In fact, it means fractionated stereotactic radiosurgery and how to mitigate the risks. So these are my disclosures. So after this, oops. So after this lecture, one should be able to describe the complications of intracranial SRS and hypofractionated SRT and to describe strategies to mitigate the complications. So stereotactic radiosurgery delivers a single ablative dose of radiation to an intracranial target volume. And in cases where the target volume is located or adjacent to elegant structures such as the optic apparatus, hypofractionated stereotactic radiotherapy is used to widen the therapeutic window. That means to decrease the risk of complications while maintaining the same local control. And these modalities utilize advanced technologies and techniques to create a very steep dose fall beyond the target and steer radiation dose away from the critical structures. So before I continue, just want to explain to the neurosurgical colleagues. So in radiation oncology, our radiation dose is not prescribed in milligrams, but rather in, a unit called gray or centigrade. Centigrade means, 100th of a gray. So there are different platforms used to deliver stereotactic radiosurgery and hypofractionated stereotactic radiotherapy, including a CyberKnife, LINAC, specialized LINAC that can deliver SRS, Gamma Knife, and there's a new system called ZAP. And basically, in physics terms, it's called gyroscopic system, and there are a few units, including one at Barrows. If you ask me which is the best system, I think there are pluses and minuses for each platform. I think most one thing is, who is delivering the treatment rather than the platform. It's just like, if I'm driving like a Porsche, I can beat Schumacher driving a Ford Taurus. So on the left side, what I'm trying to demonstrate to you is how it works. So utilizing inverse planning. So this is like a LINAC-based SRS case on the left side treating a cavernous sinus meningioma. You can see that the radiation dose is calved around the critical structure, the optic apparatus and the brainstem, while delivering a high dose to the tumor itself, the brainstem, and the right optic nerve and the optic chiasm is just getting a fraction of what is being delivered to the tumor. And on the right-hand side, what I want to show you is the steep dose gradient, steep dose of fall off beyond the target itself. So within a short distance, the dose is reduced by 40%. You can see the green line is like the 60% of what is prescribed, within the yellow line. So serious late complications are one of the most feared aspects of intracranial SRS and hypofractionated SRT. Although it is relatively rare with modern technologies and the experience gained in these procedures throughout the years, they have been observed and reported. Fortunately, many of these complications can be prevented by applying suitable strategies. So I'm going to cover radiation necrosis, brainstem injury, cranial nerve injury, and vascular injury. Both intracranial SRS and hypofractionated SRT deliver ablative doses of radiation to the target volume, as well as the brain parenchyma immediately adjacent to it, and hence predisposing the treated volume to the risk of radiation necrosis. The development of radiation necrosis is a multifactorial process that occurs when the radiation results in vascular injury and damage to the glial and endothelial cells, ultimately resulting in tissue necrosis. And it is often indistinguishable from tumor progression, with a variable clinical presentation ranging from asymptomatic and identified on routine imaging to progressive symptoms, resulting in significant neurologic morbidities. So these are the grades of necrosis that have been described. Again, it is seldom used in clinical practice because ultimately the most important thing is, the symptoms of the patient. So risk factors that can predispose patients to developing radiation necrosis, and this should be considered when you're delivering SRS or hypofractionated SRT to a target volume inside the brain. So histology, lung adenocarcinoma histology, renal histology, ALK rearrangement, perjury amplification, and BRAF V600 plus mutation could increase the risk of radiation necrosis. This is the data coming from Cleveland Clinic Foundation. And the pons and midbrain location would result in a higher risk for radiation necrosis, symptomatic radiation necrosis. And for, particularly for AVM and tumors, the radiation dose and the volume, if you have a high dose delivered to a high volume, the risk is higher. And if the patient had prior radiation before, the risk is also higher. And whether chemotherapy given concurrently with stereotactic radiosurgery or hypofractionated SRT would increase the risk of radiation necrosis. There's a mixed data. I think there's conflicting data, from UCSF and from Cleveland Clinic Foundation. And targeted therapy some targeted therapies can potentially increase the risk. VEGF, TKI, drugs like lenvatinib, those drugs used in renal cell and other like thyroid cancer, may increase the risk of radiation necrosis. And EGFR TKI like osimertinib, which is commonly used in non-small cell lung cancer, can also increase the risk of radiation necrosis. One drug that one needs to be really careful about is the HER2 targeted therapy, the TDM1. So it can increase the risk of radiation necrosis by 13.5 times if it is given concurrently with SRS. So for patients who are receiving this medication, typically if I'm performing, brain radiation, SRS, I would actually ask the medical oncologist to stop the drug for 3 days prior to the delivery of the radiation and can restart 3 days afterward. So for immunotherapy, there are mixed results. And for when you compare different strategies of SRS, say, for example, when you're comparing postoperative versus preoperative, actually preoperative SRS would result in a lower risk for radiation necrosis because typically the volume is much smaller. So, that makes a lot of sense. And also sometimes people, in some centers, they would actually give a discount of the dose delivered prior to surgery. They'll give a 20% discount. So that's the reason why, lower dose, lower volume, of course, lower risk of radiation necrosis. And however, compared to intact brain mets for the same volume, postoperative radiation, postoperative SRT or hypofractionated stereotactic radiotherapy would result in a lower risk of necrosis compared to treating a similar volume intact brain metastasis. So this is something from one of the projects by the AAPM, which is like the physics professional organization. It is a national organization, and they actually look at the parameters that, the dose and the volume relationship, in terms of the risk of radiation necrosis. I think basically they looked at mainly the data from UPMC by Flickinger and Dakansioka. So they go by the V12. V12 actually is the volume of the brain receiving a 12 gray. And in their model, actually, they included the target, inside that, the calculation, the V12. So for different regions of the brain, there's a different risk of radiation symptomatic necrosis based on the volume. And the risk actually is, the risk is different for different sites. So for like frontal lobe is lower, but for locations like the brainstem, occipital lobe, those areas would be higher. That makes sense because I think in those areas, they have some, eloquent areas controlling neurologic functions. And for frontal lobe, if you have necrosis, if the volume is small, some patients don't feel anything. It's just, you just see ugly scans. So these are also the models, for brain metastasis, for a single fraction and multi-fraction. And interested parties can, go back to the original publication, and I can, send a copy to you if you send me an email. So for radiographic findings, I think to designate, a finding as radiation necrosis, people have used different methods. So some people, they use a MRI T1, T2 matching, which compares the volume of T1 weighted contrast enhancement with borders on T2 weighted imaging. Well-correlated margins more likely to be tumor progression, while poorly correlated margins more likely indicate radiation necrosis. But again, there are always exceptions, and it's not always correct. And radiomics have been used, but they're regarded as experimental because the results are not conclusive. Perfusion scans sometimes can be helpful, and PET-CT. So before I discuss about this case, I tell you an experience. So when I was at Ohio State, I treated a patient with a melanoma in the frontal lobe in a radiosurgery. I think I gave 18 grain 1 fraction. And after the treatment, a year later, the tumor shrank, and a year later, we see an increase in the enhancement in the left frontal lobe. And when we perform a PET-CT as part of the staging workup, that area just lit up like crazy. I forgot the SUV is like, 10, 11. So we thought that was tumor recurrence. So the surgeon who initially did the gamma knife case with me went back and, I took out the tumor, took the patient to the operating room, and it's all necrosis. There's not a single tumor cell there. So sometimes PET scan can be deceiving. So this is a case, 62-year-old female with a history of limited small cell lung cancer, treated with chemoradiation, maintenance immunotherapy, and hippocampus avoidance, PCI. So in radiation oncology, there's a special technique for whole brain radiation therapy that spares the bilateral hippocampi, attempting to decrease the risk of short-term memory deficits. And it has been demonstrated in a randomized phase 3 trial that actually it can protect some aspects of the short-term memory. And later on, the patient was found to have a 2.5 cm left temporal lobe metastasis, and then she underwent gamma knife radiosurgery with 15 grain 1 single fraction. So that's on top of the whole brain radiation. The prophylactic typically is 25 grain 10 fractions, is a low dose. And interval MRI 3 months after the SRS showed interval decrease in the size of the treated lesion, as you can see in B. And in C, 8 months later, that lesion started to increase in enhancement. And perfusion MRI showed increased cerebral blood flow corresponding to the lesion. And then she underwent resection, and surgical pathology showed metastatic small cell carcinoma with necrosis. The second case showed a case that a patient who underwent PET scan, after SRS. So 60-year-old with a ER positive, PR positive, HER2 negative breast cancer with 3 cm left cerebellum metastasis. The patient underwent staged gamma knife radiosurgery, 30 grain 2 fractions. I don't know whether you guys are doing it here at Harborview, but actually back at the time when I was in Cleveland, at Cleveland Clinic, they have been doing this for a while, I think for 15 years. And actually it does work because after the first fraction, when the tumor shrank, and then you can deliver another dose there, improving the local control and decreasing the risk of complications. So initial follow-up imaging showed tumor regression, but MRI of the brain a year later showed progressive expansor heterogeneous enhancement. So this is shown in B, in the left cerebellum. And then they performed perfusion imaging was done showing elevated RCBV along the superior aspect. And then they also did a PET-CT, which showed increased metabolic activity in the area of the MRI enhancement, suggestive of tumor recurrence. But when they took the patient to the operating room and did a surgical resection, it was mainly radiation necrosis with a visible tumor, similar to my case. I had a person, actually I published that in in the melanoma journal, as a case report. It got accepted like 15 years ago. So for treatment for radiation necrosis, observation for if patients are asymptomatic, steroid, but steroid, carries a lot of side effects. Pentoxifylline and vitamin E, this is not specifically for the brain. For any radiation injury, it increases the blood flow, like radiation, we treat some patients. I mean, I've come across some patients, with a soft tissue necrosis, fibrosis, dense fibrosis, and we prescribe this medication. And bevacizumab, hyperbaric oxygen. But one thing about hyperbaric oxygen is you want to make sure that the patient is in remission, no active tumor, because sometimes the hyperbaric oxygen may stimulate the growth of an active tumor in the patient. And surgical resection, last resort. And some eloquent sites, if you cannot do surgical resection, one can do autolid. And, in the place I used to work, we do a lot of that for necrosis patients. I think you have a different system here, right, at UW. It's not called autolid, but it's a similar mechanism, right? Yeah. So strategies to minimize the risks. In general, use techniques that generate high conformality. That means, the prescribed radiation dose is basically kissing the surface of the tumor and, generate a very steep gradient, so the dose would fall off very rapidly. So in this case, when using a gamma knife, if you use multiple small shots instead of like a single biggest shot, even for a spherical tumor, that may help. But again, the drawback is if the sources are old, you will end up, spending at least 3 to 4 times, the amount of time delivering the radiation. And if you have if you're treating an AVM, if the AVM is large, you should do a volume staged SRS. This is, what, we have done, in the past, when I was treating the AVM. So you just separate the AVM into different volumes and you just determine, which is, what volume is the largest. Is you can treat, safely in one setting, and then after 6 months you treat another portion, and after another 6 months you treat another portion. So actually there's some study comparing volume stage versus dose stage. Dose stage means fractionated SRS for large AVMs. Volume stage actually results in a higher obliteration rate. So I think if it is a big AVM, do volume stage instead of a dose staged SRS. And for large brain tumors, preoperative SRS, may be a good strategy. Or one can use, if the tumor is really big, causing symptoms, don't do radiosurgery, relieve the pressure first doing surgical resection, followed by postoperative SRS, so hypofractionated SRT. Or you can just do fractionated SRT to the tumor, or you can do a stage procedure, like, the most common stage SRS strategy is to utilize 2 fractions, like, say for example, you deliver 12 gray, like right now to a bigger volume, and then after a month, you go back to tumor shrinks, and then you give another 12 gray. And for brainstem tumors, particularly if it is large, use a fractionated approach, and avoid using concurrent VEGF TKI. So those drugs are like, lenvatinib, like axitinib. So those drugs are just used to treat, targeted therapies used to treat renal cell and thyroid cancer there, or VEGF TKI, avoid using those. And avoid using, giving osimertinib concurrent with SR. So when I was still treating SRS patients here, I saw a lot of lung cancer patients on osimertinib who are EGFR positive. So basically, even in Madeline, we just mentioned that, there's some radiosensitization, and we have seen necrosis. So just stop the drug 3 days before, and then resume 3 days afterward. And the drug TDMI, don't even try, because the data in the literature is scary. Like it's like 13, 14 times higher, the risk of radiation necrosis. And also account for past radiation. So if the patient had prior radiation before, just make sure that, I think if it is in an eloquent location particularly, or if the tumor is relatively large, try to, reduce the dose, give some discount. to reduce the risk of radiation necrosis, understanding that that may jeopardize tumor control. So why do we fractionate? It is just a diagram explaining why, for big tumors or tumors close to eloquent structures, we like to fractionate. So on the left-hand side, assuming that you're giving a lower dose, there are two types of tissues, the late responding tissue and the early responding tissue. So the brain is a late responding tissue, which is like the dotted line. And for most tumors, most malignant tumors, active growing tumors, they are early responding tissues. So as you can see, if you give a single high dose of radiation, there. Actually, I flipped it. The red line is a late reaction, and the dotted line is the early reaction. And if you give a single high dose there, you can see that the red line dips, dips down, with a steeper slope. So the damage is more if you give like a high dose per fraction for late responding tissue like the brain. And for early reaction, actually damage is less to early responding tissue, which is like the tumor tissue. So when you fractionate, as you see on the right side, because the earlier part of the slope of the late reaction is less steep, so actually it would result in less damage to the late responding tissue, which is like the brain in this case. For neurosurgery, brain is the most important structure. And the early responding tissue, it would result in a more damage to the early responding tissue, which is the tumor tissue, because the earlier part of the curve is actually less steep. It's more steep. So we exploit this advantage by doing fractionated treatments. Oops. So I'm going to talk about brainstem injury. So based on the literature review, the authors have concluded, based on some literature review, the authors have concluded that, for the brainstem, even treating a lesion with SRS close to the brainstem inside the brainstem, to save maximum brain point dose is 12.5 grain 1 fraction. And it is associated with a less than 5% risk of brainstem injury. And there have been studies on SRS delivering doses up to 15 to 20 gray to the brainstem with very low incidence of complication. But one thing is, those patients, they got brain metastases. Many times they don't live that long. And so, if they live longer, they may be a higher risk for complications. So the incidence of brain injury is low among patients receiving SRS for trigeminal neuralgia when the shot is placed. The shot basically is the radiation isocenter, just to make it simple, is placed in the root entry zone, and the maximum point dose. The maximum dose of the brainstem is not higher than 20 gray. This is based on the approach used at UPMC, done by Lunsford and Conseoka and Flickinger. And data on brainstem injury from hypofractionated SRT largely derived from the studies for hypofractionated SRT for skull-base tumors, mainly vestibular schwannomas, showing very low incidence or injury to the brainstem. So strategies to avoid brainstem injury, general strategies to prevent radiation necrosis, including, what I've mentioned before. And for intrinsic brainstem lesions, use techniques that generate high conformality and the steepest gradient, or hypofractionate. That means, do it in like 2 to 5 sessions instead of one single session. And for targets close to or abutting the brainstem, minimize the volume of the brainstem, getting a high dose. And for large tumors, use multiple fractions. And in general, these are the constraints you would use for the brainstem: 12.5 grain 1 fraction, 21 grain 3 fractions, and 25 to 27.5 grain 5 fractions. This is, what you can use when you're, like treating fractionated gamma knife when you're at Harborview. So this is an example, of a case of SRS for trigeminal neuralgia. As you can see, the 20 grain line is the green line there, just barely touching the brainstem, so minimizing the amount of brainstem getting a high dose of radiation. And in patients who are undergoing repeat stereotactic radiosurgery for trigeminal neuralgia. In other words, the patient has received radiation therapy to the proximal part of the trigeminal nerve. In order to reduce the risk of necrosis of the trigeminal nerve and damage to the brainstem, one can move the shot, more distally, closer to the Mako's cave instead of, close to the brainstem. And actually, this is in France. There's a guy called Roger. He, even for like fresh cases of prior radiation, he would put the shot, more distally compared to the US counterparts. So this is an example, of some diagrams showing, what brainstem injury is like. And many a time, actually, patients do not feel anything at all. But I think it's important to, watch closely because sometimes, it's just one time point and the necrosis can actually the brainstem injury can get worse with time. And so follow those patients closely using MRI and also clinical examination. So optic neuropathy, this is actually, really a nightmare for everyone, for radiosurgeons, neurosurgeons and radiation oncologists. It is one of the most feared and devastating complications from SRS and hypofractionated SRT. The overall incidence is actually quite low, it's less than 2 to 5%. And the most commonly used constraint for optic apparatus is 8 gray. Yeah, this is actually, from like a classic paper from Harvard, from Brigham and Women's Hospital. But at that time, when they did the analysis, they used 2D diagrams to estimate the dose. And I think it is likely to be overly conservative. And subsequent data from Mayo Clinic by Bruce Pollock, who's a neurosurgeon at Mayo Clinic, show that the risk of developing a clinical significant radiation-induced optic neuropathy was 1.1% for patients receiving a single maximum dose of 12 gray or less to the optic apparatus. This is, what I've been using, 12 gray. Of course, if I can, make it lower, I'll make it lower. But sometimes if it's right next to the optic apparatus, you simply just can't, reduce the dose too much. So overall radiation-induced optic neuropathy developed in his study, less than 2% of the patients, despite that 73% received a dose more than 8 gray to a short segment of the optic apparatus. And in their follow-up study, they found that the risk of radiation-induced optic neuropathy was 0, 0, 0, and 10% when the maximum dose received by the anterior visual pathway were 8 gray or less, 8.1 to 10 gray, 10.1 to 12 gray, and more than 12 gray respectively. So I think if you if your maximum point dose to the optic apparatus, you can keep it, not higher than 12 gray, the risk of optic neuropathy. Actually, basically, I've never seen an optic neuropathy. And I've, done over, like close to 2,000 cases in the past, and I've never seen a single case. So data on optic tolerance for other hypofractionated regimens, that means more than one fraction, are limited. Overall, the incidence is very low, and commonly used constraints are, if you're using 3 fractions, 18 to 21 gray, and if it's 5 fractions, 25 gray. Most recently, the American Association of Physicists in Medicine Working Group on SBRT published SRS and hypofractionated SRT dose of optic pathway. 34 studies were identified with data of close to 1,600 patients included. And in patients with no prior radiation before receiving SRS and hypofractionated SRT, the maximum point dose of less than 10 gray in 1 fraction, 20 gray in 3 fractions, and 25 gray in 5 fractions resulted in less than a 1% risk of radiation-induced optic neuropathy. So strategies to reduce the risk of complications: contour the whole optic apparatus, because if you miss out part of the optic apparatus, you don't track it, you don't know it, and you give the dose inadvertently, and you may risk damaging the visual pathway. Limit the volume of the optic apparatus receiving the tolerance dose, and sometimes, if you're still using a frame-based treatment, by orienting the stereotactic frame parallel to the long axis of the optic nerves. You can see that, on the sagittal MRI. so that the anteroposterior axis of the peripheral isodose will be parallel to the optic apparatus on the sagittal plane, because the fall-off of the radiation for gamma knife is much steeper in the superior inferior direction compared to like the radio directions. So you can exploit that advantage in resulting in a lower dose to the optic apparatus. And the use of, if you're using gamma knife, using small shots, like 4 mm shots, can also steepen the dose gradient, potentially decreasing the dose delivered to the optic apparatus. And with the new planning software, one can do automatic beam shaping using perfection or icon. And that can also facilitate the sparing of the optic apparatus. And if a linear accelerator or robotic system is used, the use of inverse planning, that means, you just tell the computer, limit the dose to, say, for example, 12 Gray in 1 fraction. The computer automatically calculates for you and steer the dose away from the optics to not higher than 12 Gray in 1 fraction. So strategies to reduce the risk of complications is, respect the tolerance, 10 to 12 Gray in 1 fraction, 20 Gray in 3, and 25 Gray in 5 fractions. This is the based on a model developed by the AAPM, which is the physics organization I mentioned about. So this is what I'm talking about, control the whole optic apparatus, not just the optic nerves, the optic chiasm, but also the optic tracts. I've seen, some brain mets, they're right next to the optic tracts, posterior optic tracts, and many people do not contour the optic tracts, and one can potentially overdose the optic pathway without even knowing about it. So I'm going to talk about the toxicities of 3rd, 4th, 5th, and 6th nerves. So the situations in which these nerves can be injured from the radiosurgery or hypofractionated SRT, or when cavernous sinus meningiomas or pituitary adenomas are treated with a radiosurgery. And data in the literature on SRS for skull-based meningiomas seem to suggest that these nerves, they are able to tolerate a single high dose of radiation quite well. So this is, I'm sure that you're more familiar, with the anatomy than me, but, as a radiation oncologist, this is the best I can do. So you can see that anyways, it doesn't show on the computer screen. So you can see that, if there's a pituitary adenoma, particularly a macroadenoma, it can invade the cavernous sinus, and these nerves can be affected, the 3rd nerve, the 4th nerve, the abducens nerve, and V1, V2. The V3 typically is more inferiorly located. And if it is a cavernous sinus meningioma, the same structures will be affected. So Tom Witt, he is a colleague of mine when I was working at Indiana University. He trained at IU and then UPMC. And he looked at all the data on SRS for pituitary adenomas. There were a total of close to 1,300 patients who underwent SRS for pituitary adenomas with a marginal dose ranging from 12 Gray to 34 Gray in 1 fraction. And given the proximity of the cell to the cavernous sinus and high doses used to treat pituitary adenomas, especially secretory tumors, the cranial nerves in the cavernous sinus can potentially be exposed to a very high dose of radiation. However, the overall incidence of permanent 3rd, 4th, 5th, and 6th nerve neuropathy was only 0.4%. However, dosimetric analysis is lacking because there's no way in which you can, control each nerve on the MRI, in a gamma knife plan. And it is unclear exactly how much radiation is actually being delivered to those cranial nerves. It's just by inference, we're just guessing, which can be difficult to visualize. So one thing is, for patients getting a high dose of radiation, like 34 Gray in 1 fraction, but those patients usually have a microadenoma, so it's confined to the cell itself. So the doses to those cranial nerves, the 3rd, 4th, 5th, and 6th nerves, may be actually lower than what is prescribed to the high dose of radiation to the microadenoma. So we're just guessing. So when we look at the, so when a cavernous sinus is invaded by a meningioma or a microadenoma, those nerves are likely to be included in the tumor volume to be treated and are likely to receive the prescribed dose, except for the situation where the patient has a microadenoma, which is confined to the cell itself. But many times we treat those microadenomas, they invade the cavernous sinus. So based on the doses used in various studies, it appeared that for SRS, the usual dose of a 14 to 34 gray in 1 fraction used for pituitary adenoma, and 12 to 18 gray in 1 fraction used for cavernous sinus meningioma, I expected to result in a risk of injury to those nerves. One note of caution, as I mentioned before, is although a single dose of up to 34 gray has been used for pituitary adenoma during SRS, this regimen is only used in secretory microadenomas, and the doses delivered to those nerves are likely to be much lower. If you're using more than 1 fractions up to 5 fractions, the use of regimens of 21 gray in 3 fractions and 25 gray in 5 fractions appears to be very safe for those cranial nerves. Although the exact tolerances of those nerves are unknown, it is imperative that every effort should be made to minimize the high dose spillage by creating a highly conformal isodose distribution. So that means the prescribed radiation dose line should be basically kissing the surface of the tumor. Because there could be significant hotspots inside the prescribed target. Usually it's 50%, because we prescribe to 50% for gamma knife, that means the hotspot can be 2 times as much inside the target itself. And for Linac base or CyberKnife base is 70 to 85%. That means the hotspot, that means the dose inside the target itself can be like 40%, can be like 15 to 40% higher than what you prescribe to the periphery of the tumor. So given the lack of information regarding the exact tolerances to those nerves, it's imperative that every effort should be made to minimize the spillage by creating a very conformal isodose distribution around the periphery of the tumor. So by limiting the spillage, high dose spillage, which if involved by the tumor are expected to be those nerves, which if involved by the tumor, being pushed by the tumor are expected to be at the periphery of the tumor, can be spared of an excessive dose of radiation from the hotspot. So it's okay if the nerves are getting what is being prescribed to the target, but if it's like slightly interior to the periphery of the dose would be higher, so one can potentially basically cook those nerves. So I'm going to talk about, the 7th and the 8th nerve. So most of the data on the toxicity of these nerves came from SR series for vestibular. So in an early series reported by Dr. Seok, it was published in the England Journal of Medicine in 1998. I remember when I was a resident, we were discussing about this paper. At that time, the standard was a 14 to 20 gray for gamma knife for this, for vestibular, and the hearing retention was horrible, 47%, and the risk of the 7th nerve injury is 15%, which is much higher than what we see in modern day radiosurgery. And in more recent studies, and because of these results, the group at UPMC, they decreased the prescribed dose to 12 to 13 gray in 1 fraction, and the incidence of hearing loss reduced significantly. And the hearing retention was 88% with gamma knife. And in terms of the toxicities of the cranial nerves, including the 7th nerve and the 5th nerve, is on the range of 5 to 7% reduced to. So protons have been used to deliver SRS, but the hearing preservation rates were lower. It's actually much lower than anything else, even lower than using a higher dose to treat vestibular. It's only 30% of hearing preservation. And they used a dose of 12 gray in 1 fraction, and that was the result from MGH. So I think the reason to explain that is when you compare the isodose, the radiation dose, around a tumor in terms of how conformal it is to the tumor itself, actually protons are worse than gamma knife or LINAC or CyberKnife. And also, for proton therapy, they utilize what we call a Bragg peak, which is like at the end of the range, simply there would be a spike of the dose and then it drops to zero, the dose. And at the end range, there's actually more uncertainty in terms of actually, there's something what we call the relative biological effectiveness. That means the effective biologic effect of the dose. It's not exactly what you see on the face value. It can be like 20 or 30% higher. And so because of that reason, that may explain why the results of protons are worse compared to photon-based like SRS with gamma knife, CyberKnife, or LINAC. And in terms of multiple fraction stereotactic radiosurgery, less data is available. However, based on the analysis of literature, a use of 18 to 21 grain free fractions and 25 grain 5 fractions result in a less than 10% of 7 nerve injury and 50 to 80% cervical hearing preservation. So we stick with that usually. So strategies to reduce the risk of toxicity: choose the appropriate dose, as I mentioned before. So if you're using a single fraction, don't go more than 13 grain 1 fraction. Typically what I do is, if the tumor is touching the brainstem, I would go to 12 to 12.5. If it is away from the brainstem, I would go with 13. And minimize the high dose spillage by creating a plan with high conformality index. The same thing. And do not use protons for SRS for schwannomas. So this is diagram. Actually, I drew it myself. Sorry for torturing you, but hopefully you see what I'm trying to show. So this is a highly conformal plan here. This is the Vesper schwannoma. The reason why I'm drawing it myself is because I can find like the art department. So I just decided rather than wasting time doing it, why not just do it myself? So this is a Vesper schwannoma here. The red line is the 13 gray line. So the nerves are just at the periphery of the tumor. So if you have a very conformal plan, the nerves are getting not higher than what is prescribed to the tumor. Versus if you have a sloppy plan, see there's a 13 gray, and there's a lot of high dose spillage. Anything inside this target is getting 13 gray or higher. The nerves are being cooked because the nerves, say for example, this is 13 gray to periphery. The center part of the tumor is getting 15 gray. Here, the same thing. The red line is 13 gray. It's 15 gray, and then nerves would end up getting 15 gray, a higher dose. The reason why it's really important to generate, a plan with excellent conformality. So for cranial nerves, finally, I'm talking about the last 4 cranial nerves, 9, 10, 11, and 12. So the toxicity data on these nerves are mainly extracted from studies on SRS for glomus tumors, because the glomus jugulare tumors, which are located close to the internal jugular vein. And there have been 2 meta-analyses examining the outcomes for SRS for glomus tumors from Hopkins and from UCSF. And in the meta-analysis from UCSF, they look at 339 patients treated with SRS alone, and the incidence of toxicities to those nerves are roughly 10% when a median dose of 15 grain 1 fraction was given. So this is a diagram. I'm sure that you're more familiar with this than me, but as a radiation oncologist, I think this is the best I can do. So this is the jugular foramen, as you can see here. This is the sigmoid sinus, and these are the 9th, 10th, 11th, and the hypoglossal nerve is actually close by. When you look at this, it's all in a cluster. So we have a glomus tumor here. It would, push the tumor will be basically kissing those nerves. And if you treat with a stereotactic radiosurgery or hypofractionated SRT, make sure that you generate a really, really conformal plan, because the nerves are in the periphery of the tumor. And if you generate a plan that has a lot of high dose spillage, that means the prescribed dose is also including, more tissue beyond the target. then the nerves being pushed to the periphery, by the tumor would receive a much higher dose. Sharma from Cleveland Clinic Foundation reported relatively low rates of cranial nerve toxicities after gamma knife-based SRS for glomus tumors with a dose of 15 grain 1 fraction, which is actually compatible, which correlates with what was seen in the meta-analysis I described previously. And at UT Southwestern, there was a study using 25 grain 5 fractions for glomus tumors, and there was no grade 3 or higher toxicities in terms of cranial nerves. And so if you're using fractionated, typically I stick with 25 grain 5 fractions. Because one issue is if you're having high dose spillage, for a glomus tumor, you're actually wrecking 4 cranial nerves, not just, 1 or 2. So strategies to reduce the risk of toxicities: choose the appropriate dose and minimize high dose spillage by creating a plan with a high conformality index. So finally, I'm going to talk about vascular injury. The circumstances in which major vessels, such as the internal carotid arteries, are usually exposed to high dose of radiation occur when cavernous sinus meningiomas and pituitary adenomas are treated with SRS, a hypofractionated SRT. And Dr. Witt from Indiana University, performed a systematic review on patients with pituitary adenoma treated with SRS. This is a study I mentioned before, and found that among the 1,255 patients evaluated in the studies, there were only 3 cases of internal carotid artery stenosis or occlusion. In one case, the dose to the internal carotid artery was estimated to be less than 20 grain 1 fraction. So it was recommended that less than 50% of the circumference should receive the prescribed dose, and the internal carotid artery should be kept below 30 grain 1 fraction, the maximum point dose. So in a Mayo Clinic study, actually look at patients who got cavernous sinus meningioma and pituitary adenomas treated with SRS. And the pre-SRS internal carotid involvement was created based on a Hirsch scale. And for those patients, just for the sake of comparison, for those patients with pituitary adenoma, they just try to convert to the equivalent scale for pituitary adenomas, because pituitary adenomas are evaluated using a different vascular scale. So the median time to stenosis was around 5 years, and the stenosis rates for Hirsch categories 1 and 2 or 3 were 0% and 7.5%. It was a 0 and 7.5%, and was 0 for 1, and for 2 to 3, 7.5% in 5 years, and 12.4% in 10 years. And the risk of an ischemic stroke was 1.2%. So this is, what I talk about the Hirsch categories, and the NOSP grading was used for pituitary adenomas, but it was converted to Hirsch categories. This is roughly, how they did the conversion. And median prescribed dose was a 15 grain and 25 grain in 1 fraction for meningiomas versus growth hormone secreting pituitary adenomas. And based on the multivariate analysis, they show that SRS internal carotid grade, how much it is involved, the age and pathologic diagnosis, high risk for the cavernous sinus meningioma, predicts stenosis or occlusion with no significant association between any dosimetric parameters and stenosis or occlusion. I think the main reason why meningiomas are more, would carry a higher risk for stenosis is because it has tendency to circumferentially, encompass the internal carotid artery compared to pituitary adenoma, which tends to, push the internal carotid artery. So for patients getting multiple fraction SRS, there was no vascular injury reported when you give a dose of 19.5 gray to 21 gray in 3 fractions or 25 gray in 5 fractions. So strategies to minimize risk of vascular injury: there's no concrete dosimetric guidance, based on the data from limited literature, it is prudent to avoid having 50% of the circumference receiving the prescribed dose and to limit the maximum dose to 30 grain 1 fraction. And for multiple fraction SRS, one can consider using 19.5 to 21 grain 3 fractions, 18 to 20 grain 4 fractions, or 25 grain 5 fractions with zero risk of vascular injury. And it is also prudent to avoid irradiating more than 50% of the circumference in internal carotid artery, as in the case of a SRS. So before I talk about the take-home points, one thing I want to mention is, when I explain to patients the risk of a stroke after radiation to the internal carotid artery, whether it's SRS, hypofractionated SRT, proton therapy, or regular conventional radiation, I tell them, the development of an ischemic stroke is multifactorial. There's some factors you can control and some factors you cannot. So the injury of the artery will happen. But, also apart from that, their baseline medical condition, can also affect the risk. Let's tell them, control your blood pressure, your blood sugar, your blood lipid. That way, that may, decrease the risk, although the risk caused by the narrowing of the internal carotid artery, you cannot control that part. But, there's some part that they can do that can reduce the risk of a stroke. So take-home points. The goal of reducing radiation-associated complications begins with high-quality radiation planning with very high conformality, as well as a very steep fall-off of the radiation dose. And be mindful of V12 in SRS to minimize the risk of radiation necrosis. And if the volume is large, use multiple fractions, up to 5. And for brainstem lesions, even very small volumes can safely receive a high single fraction dose, as evidenced by the data on trigeminal neuralgia patients receiving SRS. And the cranial nerve deficits, generally speaking, caused by the radiation, is relatively low in general. However, those toxicities does not occur immediately. It can happen 5 years, 10 years later, or 15 years later. Many a time, it can be due to vascular injury or fibrosis of the tissue surrounding the nerves. So vascular complications can occur, and while practice patterns are evolving, for SRS, a maximum point dose of 30 gray is recommended. And for pituitary adenomas, also attempt to keep less than 50% of the circumference of the internal carotid artery receiving the prescribed dose. So that wraps up my presentation. Thank you very much for inviting me to speak.
Thank you. That was great. Simon, any questions for Simon? Dr. Lowe.
Thanks, Simon. One of the things that wasn't talked about was neurocognitive changes. And I'm wondering if, especially say pediatric patients with cellular or supracellular pathology, where they're not getting whole brain, but they're getting, radiation to that cellular and paracellular area. What's your experience in, I guess, a pediatric population versus an adult population in terms of any neurocognitive deficits that might result from treatment?
So I would say in adults, amount of patients getting SRS, depending on the diagnosis, I think for the brain met patients, even without any treatment in baseline, without chemotherapy, you actually detect some neurocognitive deficits. There's a study from MD Anderson Cancer Center. It was published around 20 years ago. They show that, it was published, I think, in JCO or something like that. Without any treatment, actually, the baseline neurocognitive function is inversely proportional to the size of the tumor, total volume of the brain metastasis in the brain. So if you have a bigger volume of bigger tumor load in the brain, the risk of neurocognitive decline, before any treatment is higher. And also patients, getting chemotherapy, some of the drugs used to treat breast cancer, can also cause what they call a chemo brain. And usually for benign tumors for adults, I think most patients have not, because you typically, if the patient doesn't complain, you don't do any neurocognitive function. You only do it in a clinical trial, but really not, in a daily clinical setting. I haven't actually observed any evidence that, patients, having, memory issues or things like that. And for pediatrics, in the olden days, I used to treat pediatrics. I haven't treated pediatrics for 13 years, but, for the radiosurgery patients, typically, because they're pretty young, those patients, but, for those patients who have been followed by me for a few years, I really have not noticed, much difference in, in terms of the school performance and things like that. So for kids, school performance is a good indicator of the neurocognitive function.
Thank
But I
you.
think, for external beam radiation, the risk is definitely higher, but a lot of those patients have a more severe diagnosis, like, gliomas, brainstem gliomas. And those patients, they typically don't live long enough, many of them, to experience the neurocognitive issues. But for benign tumors, like AVMs I treated, those kids, I have not seen any significant difference in the school performance and things, based on my past experience treating pediatrics.
Okay. Thank you.
One more comment is, I think, across the board right now, the areas that we know that are responsible for short-term memory and neurocognitive function, mainly short-term memory, are the hippocampi. And so we try to minimize the dose of the hippocampi. So we contour the hippocampi for all brain cases. And there are also other centers that have not been well established yet in the brain, but the hippocampi, is the gold standard right now for us